Well, good evening, everyone, and thank you very much for coming. Firstly, may I introduce myself. My name's Malcolm Horne, and I have three affiliations. I'm associated here with the Florey, where I have my research laboratories. I'm a movement disorder specialist at St Vincent's Hospital, where I see people and treat people with Parkinson's disease, and I'm affiliated here with Melbourne University through the Florey. Secondly, can I issue an apology? I seem to have developed hay fever, and if I have to resort to having a sniffle every now and then, my apologies, but I hope it's not an uncontagious form of hay fever. Can I also ask, can you hear me properly? No? I will try and speak up if I can, but unfortunately there's microphones here, and it's a little bit hard to make sure, but please put your hands up or call out if it's becoming difficult to hear me. Now, this is a series of lectures who are directed at people who are living with Parkinson's one way or the other, and this particular lecture today is part of one of three. It's directed first of all at the oral medications that people take with Parkinson's disease to control its symptoms. The next lecture, and so I'm only going to briefly cover some aspects of this, are those regarding the advanced therapies. Those are deep brain stimulation and the various pumps for delivering continuous therapy. And these are a more complicated form of therapy, and I'm going to devote a whole lecture to the pros and cons and how to choose those. And the last of the series will be directed at the other problems of Parkinson's, which are really quite significant and are not readily treated by medications and the other therapies and options that are available for treating them. So this is, just to re-emphasize, this is particularly related to how to use the oral therapies, which are the mainstay of treating Parkinson's. Now, if we think about, this is a cartoon about what might happen with Parkinson's disease, and if you think of the idea that people are completely well, have 100% of the nerve cells that are affected in Parkinson's, and when they develop it over some period of time, these progressively dwindle over the years that are present. And if we were able to start treating people with Parkinson's with the medications that we've got, there might be an improvement in symptoms which might last for a period of time and then finally lose their efficacy. And these are called symptom modifying therapies because they're not able to control long-term the process, and they only work for a period of time. Now, what's going on underneath the process of the development of symptoms is there's a steady progression of loss of nerve cells. And by the time Parkinson's presents, in fact, there's really only about 30% of nerve cells, particularly the dopamine cells, that are still present. So this is the idea that they're way out here somewhere. There must have been a process that was beginning before the symptoms occur, which we call pre-symptomatic disease, and I'm not going to talk about that today. But if we were able to, in some way, arrest the cell death so that disease wasn't continuous death, these would be called disease-modifying treatments. And this is what we would aspire to, and what much of the research is directed at is trying to produce these. But unfortunately, at present, we have a lot of symptom-modifying drugs, but we have either few or none, we're not quite sure of the answer there, of disease-modifying drugs. And if I have time, I'll come back and address this question, but most of what we have are these symptom-modifying drugs, and so they are directed at trying to ameliorate or reduce the symptoms as much as possible. Now, this shouldn't be just simply dismissed as only modifying symptoms. This year is the 50th anniversary of Levodopa, the mainstay of treatment. We're still using it 50 years on. And as best as we can, if we look back over the history and try and trace what the life expectancy of people prior to the arrival of levodopa, it was significantly less and significantly worse. So although in some ways we call this only a symptom-modifying drug, it actually has prolonged the life and reduced the disability substantially, enormously indeed, of people with Parkinson's. And so it's probably a little bit of a misnomer to say that it's only modifying symptoms. Now, the main symptom-modifying drugs that we have relate to a part of the brain that's called the dopamine system, and I'm going to talk a little bit about that so that you understand how the drugs work. And this goes back to a little bit of history that those of you who've been attending these lectures will have seen just a little bit of these slides before, but I'm just to use it to put it in context. These are quite old discoveries. This gentleman in 1895 was the first to recognize that this part of the brain here, called the midbrain in the substantia nigra, the nerve cells there disappeared when in the presence of Parkinson's. And what he noted was that this little series of black structures around here, this is if we were to cut the brainstem through here, you would see that in people without Parkinson's, who at the time of their death would have these little black marks sitting here, and that's what's given this area of the brain the name the substantia nigra, which in Latin is black substance. And he noted that with people who had Parkinson's at the time of their death, that this black area was missing, and that led to drawing attention to what was going on in this area. Then in 1958, these two people who subsequently got the Nobel Prize first of all discovered that this area here was black because it had a molecule in it called dopamine, and that its oxidization was what led to this region becoming black, and then to the understanding that this was the nerve transmitter in this region, and finally this gentleman, Kotzius, used this medication called Levodopa to induce the regions in this part of the brain to make more dopamine and thus to alleviate the symptoms of Parkinson's. And as I mentioned, it's close to the 50th anniversary to which the very first trials, I've got 1968 there, but that's when it became routinely used, but the therapy began earlier than that. So what is going on in this part of the brain is that this is these areas, the little black regions here, and that's where the nerve cells, the cell bodies, live. And nerve cells send out long processes known as axons. And at the end of the axons are specialized regions called terminals in which these chemicals like dopamine are held in little bags ready for release and therefore to communicate with their neighboring cells. So the dopamine is the machinery down here for making dopamine is sent up here, and these little terminals at the end, there's a cartoon of what they look like. They contain bags, and inside the bags are stored the dopamine. The dopamine is made by a molecule called from tyrosine, and it requires a series of enzymes to make it, and these are rather slow, and levodopa can go in and speed up the process. When a nerve cell has an impulse, it spreads down here and leads to these little bags coming close to the edge of the terminal, and it releases the dopamine into the end, binds with receptors on the other side, and that produces a signal, and that leads to the communication between one nerve cell to the next. This dopamine is then rapidly taken back up again by a specialized molecule here, packed back into the bags again, ready for reuse. And so that's the heart of the machinery that we're going to talk about, and where these molecules, the drugs that people use for treating Parkinson's act. So there are two main classes of medications, one related to levodopa, which I've already talked to you before, and the second is these D2 agonists. Now levodopa, brand names here are Madapar, Sinemet, and Kinson. Levodopa is a precursor to dopamine, and it can be converted to dopamine immediately without going through the slow machinery of converting tyrosine by this enzyme called TH, which makes dopamine, which is a very slow process. So it speeds up the mechanism and goes immediately in there and creates much faster synthesis of levodopa for the remaining nerve cells to use and therefore to work harder. And that's a key idea. Levodopa only works in the regions where the nerve terminals have gone missing and makes those regions work harder. And that's a key concept because it relates to some of the side effects and complications that I'm going to talk about. The other molecule, these ones that are called D2 agonists, and they're called D2 agonists because agonist means is a in-house way of explaining that these molecules mimic the action of dopamine, and they're agonistic instead of antagonistic is what it's meant to refer to. So these are, in more approachable language, they're dopamine lookalikes. The receptors on the nerve cells here, when they encounter these molecules, they mistake it for ordinary dopamine coming across the nerve terminal. They're called D2 because there's two types of specialized receptor molecules here. One called D1, which is also for doing specialized actions of dopamine signaling, and these D2 ones which have a separate role. And these seem to be the most efficacious in mimicking dopamine in terms of some of its functions for Parkinson's. Now, the common names for these D2 agonists are Cifrol, Cabasar, Rotigotine or Nupro as on the patch, and they're the common ones that you might see from your doctor's prescriptions. There's another class of helper type drug. They're not the mainstream, but they help the action of these, which are ones which block the clearance enzymes. So there are enzymes in here which mop up any excess dopamine and take it away. And they have, one of them is an enzyme called catechol O-methyltransferase, or COMT. And if we could inhibit that enzyme, then the dopamine wouldn't be cleared as quickly, and it would last longer and have a longer duration of action. A common molecule here is Comtan, and another one is where Comtan is packed with levodopa, and then it's called Stalevo. And there are two of the pharmaceutical names that you would have. There's also another molecule called monoamine oxidase, or MAO, which breaks down dopamine, and two of the molecules which block that action and have the same process of making the levodopa last longer is rasagiline and selegiline, and they are two commonly used drugs in ordinary pharmaceutical treatment of Parkinson's. This one not so common, but this one is still quite frequently used. So when we use these drugs, I'm going to stay here because I think the microphone's a bit better, isn't it? Is that right? Yeah, I'll stay here. So when we use these drugs, what are we trying to treat? Well, the key symptom of Parkinson's is this condition called bradykinesia, which literally, it's a Greek word which literally translated means slow movement, and that's the main abnormality that absence of the dopamine in the substantia nigra produces, and that's this slowness of movement in terms of difficulty doing up buttons, small handwriting, loss of facial expression, difficulty swallowing causing dribbling, low volume of voice, loss of arm swing, slow difficulty of initiation, trouble rolling over in bed. All those things come out of this problem of bradykinesia. So the key target we're trying to treat is to alleviate that bradykinesia. And a lot of the other symptoms that you see in Parkinson's, such as the tremor and the rigidity, are consequences of the bradykinesia. So again, that's why this target is the bradykinesia. If you can knock that, a lot of the others will improve on the coattails. The second reason we treat the bradykinesia is it's the most significant reason why there is impairment to quality of life, much more so than tremor and rigidity, which I'm going to talk about shortly. So I've mentioned rigidity. We do try and treat it, but it's one of the things that patients are actually not as aware of as we are as doctors, because we examine the limbs and it shows up to us as difficulty of moving the limbs backwards and forwards and some degree of stiffness in the neck and the trunk. And this is not usually apparent to the patient. And so although when you look up on the web or in textbooks you'll see that what are the key signs of Parkinson's, and rigidity is one of them, that's a sign to the neurologist rather than something that causes most people problems. However, some people do get pain, and there's a suggestion that some of the vague discomfort, particularly in the muscles of the limb, might be due to that. Shouldn't be confused with the pain that occurs in the joints, which is very often the normal rheumatism that comes from having too many birthdays, and that's simply exacerbated by lack of mobility rather than actually a prime cause from rigidity. Tremor is also a key feature. It's not such a big target for levodopa, and in fact levodopa is only moderately successful in taming the tremor. Tremor is often very significant to the patient, and that's often why people end up coming to their doctor, because they notice the tremor. Usually, however, the tremor is only present when the hand is not doing anything, and as soon as you use the limb and move it to actually go to a target, the tremor suppresses. And so its key problem is then usually embarrassment and the sense of reminding you that there's something wrong rather than it actually getting in the way of doing things. Occasionally, and in a small number of people, it's severe enough to make it hard to keep the peas on the fork or to actually hold a glass, but that makes us wonder whether in fact the tremor is really entirely due to Parkinson's, and we look at other things. There are other aspects of Parkinson's which can sometimes get better with levodopa, but not always. There's this condition called dystonia, and this is most commonly seen in the foot. It's where the big toe goes up in the air and the little toes and the other toes curl under the foot. It's usually present when the medications aren't working, particularly first thing in the morning when you get up and put the foot on the ground, but it can reappear as the medications wear off. And so levodopa or the dopamine medications are useful in trying to alleviate that symptom. It can occur in other parts of the body, but that's the most common location. I've mentioned pain before, and again, levodopa or all of the medications are useful at controlling the pain, and it's one of the features that come back if pain is part of the syndrome that people are encountering. I've put up cognition because there are many, and we'll cover this in future discussions, not today but at other times, but there are many ways in which cognition can be affected by Parkinson's, but there's one particular one which is helped by the medications. In the same way as the movements are slowed down in Parkinson's, so can the thinking be slowed down. And people can find that they just find it difficult to solve a problem. They can see that this ought to be a tractable thing, that they can see that there should be a way around that, but somehow or other it's just harder to nut your way through it, and you get a bit more flummoxed by problems that used to be quite biddable and easily solved in previous times. Usually as the bradykinesia, the slowness of movement, improves, often this aspect of thinking will get better as well. And so it is one aspect where cognition, people feel brighter and just can think a bit more easily, and it's often one of the things that people around you would notice as that aspect of thinking got better. Now, what are the side effects of these medications? We talked about what we're aiming to do with it, is we're trying to improve that slowness of movement, and that's the key aim we're trying to get to. Now, both types of medications, whether they're D2 agonists or levodopa, can cause side effects. Note my wording there, can, not will, but can. And these are common side effects that can occur. Both of them will cause sleep disturbances in a proportion of patients, and these can vary from drowsiness, particularly with levodopa, within half an hour to an hour after taking the dose. It's usually short-lived, about 20 minutes or so. Sometimes it's caused by low blood pressure, but sometimes it's the medication itself. It can also cause a long-lived propensity to be finding it much easier to drift off to sleep when you sit down and do nothing. So the That just simply means sitting down to watch the television seems to be a much greater invitation to doze off than it used to be before. It can also cause some disturbances, paradoxical disturbances at night. It may make some people wake up during the night and can cause vivid dreams disturbing their sleep as well. So it can both cause daytime drowsiness and also can cause impairment to sleep. We don't know why this is, because we normally think of dopamine in most physiological circumstances is a molecule that wakes people up. We know that it has something to do with sleep, but we don't know quite why in this setting it actually seems to cause sleep to occur rather than cause people to wake up. But it's a well-recognized feature that sleepiness is more common. With the dopamine agonists in particular, it seems to be that sleep, sorry, I just meant to show this slide here. This is a slide which I'm from the one of the Parkinson's kinetographs, which is a way of measuring movement. And this is the time of day along here, from early in the morning to late at day. The red lines are when medications were taken by this patient, and the blue lines is the bradykinesia. So it's very marked bradykinesia here. They take their medication, it gets better, then it wears off, gets better, it wears off. This is a typical fluctuating course. But these black lines here are the 10 days for which the device was worn, and the black lines are when the person became so still that they'd gone to sleep. And you can see that after almost every dose, this person goes to sleep. And when other types of medications were used to remove this medication, this fluctuation, in fact, this sleepiness went away. So with the other thing I was going to say, though, is that with dopamine agonists, in a very small number of patients, there is a propensity for a condition called the nods, in which people will abruptly and briefly go to sleep. Now, this can occur under a number of circumstances, and not necessarily because the situation is boring. It can occur during conversations, during eating a meal, and you can see that this is of particular relevance driving. And so if you're on one of these medications like Cifrol or Cabasar or Nupro, then it's a condition that you should be aware of in case you are one of the people who has that problem. Because of this problem of sleepiness, though, it is also something everybody on Parkinson's medication should be careful about when driving. I'm getting ahead of myself. Another common problem is low blood pressure. Now, one of them, a rare but troublesome time is when people first take the medications. On the very first day, some people get a very marked drop in blood pressure. Quite a frightening thing if it occurs, but it's usually quite harmless, and on the second time and third time, the same problem doesn't occur. So it's one of the things we warn people of. It doesn't happen very much, probably 1 in 1,000 or so patients. A very common time for it to occur is immediately after meals. Post-breakfast is the most common one, and it can be confused with sleepiness at that time, so that instead of the drug having the effect that I spoke of before, what's really happening is that the blood pressure is going low, and if we treat the low blood pressure, then those patients actually find that the sleepiness goes away. And a common reason for this to occur is because people have been dry overnight, and then instead of topping up with the fluids immediately afterwards, they take the medications, which then drop the blood pressure a little bit more, combined with eating food which shunts blood away to the gut, away from the brain, and all of that together leads to low sleepiness and drowsiness or lack of attention in that immediate post-breakfast period. It can occur at other times, but that's a particularly common time. Low blood pressure can also occur out of the blue, usually when you first stand up at any time, and can cause people to faint effectively and black out and therefore have a fall. So if you are getting head spins when you stand up, and this is occurring relatively frequently, it's something you should discuss with your neurologist because it can be treated. It may be best treated by altering the size of each dose and making them more frequently, or there are other medications available for managing the effect of low blood pressure. Excuse me, that hay fever is attacking. Nausea is quite a common problem, particularly when the medications are first begun. And this is because there's a region in the low part of the brainstem which is acutely sensitive to molecules that contain chemicals like dopamine. Tyrosine and dopamine are closely related to those processes in ordinary plants, which cause them to go brown with bruising and fermentation and when the food goes off. We think that this receptor in the base of the brain is to pick up eating food that's either dangerous to you because it contains these dopamine-like molecules or because the food is damaged. The problem is that it acts by causing nausea, and so at the first time when you're given the levodopa or the dopamine agonist, then it produces a feeling of nausea. This usually occurs with a sense of a bit like morning sickness, a bit queasy in the morning, doesn't usually get to frank vomiting, but you're off your food, don't really feel like eating, passes, and then pretty good till lunchtime, have your midday dose and back it comes again. It usually only lasts about half an hour, 6 months I should say, and it can be treated. So again, if it's present, speak to someone because it can be controlled, and not all nausea associated with Parkinson's is due to the medications. Reflux and stomach ulcers can affect people with Parkinson's, and indeed they're a little bit more common in people with Parkinson's, and so it's worth discussing it if it's present. Motilium is the common medication for treating these periods of nausea. You treat it for 6 months, and if it comes back, when you increase the dosage, it may return, and then you may need a small dose of it, again to control that period of nausea. But something I will talk about a little bit further is other mechanisms of nausea later on. Now, a key problem is these abnormal involuntary movements, and this eventually becomes one of the major problems with using the treatments for treating bradykinesia. Their common name is dyskinesia. They're difficult to distinguish from tremor for many people because they seem to be excessive movements, and so people think of the two things as coming together. However, these are quite different. They never occur in people without Parkinson's disease, but they're not actually caused in the sense of being a side effect. So if you give someone who hasn't got Parkinson's levodopa or the dopamine agonists, they don't get dyskinesia. You don't usually get dyskinesia in early PD, but it does occur later on in the disease. So what we understand from that is that it's not the drug itself, but it's the drug plus established disease or disease that's been present for a period of time together that produces it. So it's not really the consequence of the drug alone, it's actually the duration of the disease, the length of time that it's been present. When it is present, it's a major, and we can't control it, and this is one of the things I'm going to spend a bit of time talking about later on, then it's a time for one of the advanced therapies such as deep brain stimulation. And I'll talk about those later on. The last important common side effect is this problem of neuropsychiatry. I've mentioned before that these anti-Parkinson's drugs that affect dopamine often improve thinking and make it easier to solve problems, but it can actually, at higher doses, lead to the thinking to become too fast and too pressed, and eventually for people to become impulsive. And this idea of impulsivity and what we call impulse control behavior is a very common problem, and is most common with the D2 agonists more than with the levodopa per se, but it can occur with both. Finally, there is this problem of hallucinations and sometimes a degree of paranoia. And this is again one of the problems that's a consequence of the duration of the disease primarily, but it's exacerbated by the drugs. So again, often the drugs are blamed, and certainly they exacerbate the problem, but the fundamental cause is the duration of the disease and the fact that it's gone to a certain stage. Now, there are some problems which levodopa seems to, the D2 agonists seem to produce more than levodopa. In particular, it can have an effect on mood. Now, some of them, particularly cifrol, pramipexole, may actually be an antidepressant in some people, but paradoxically, in a small proportion of people, it can make them much more irritable than they would otherwise be, and can even make some people quite aggressive, and this can occur quite early on in the disease and catches you a bit unawares because it's often quite out of character. So it's one of the things that we need to be wary of when you first take the drug and ask around about this change in behaviour. They are probably a bit more likely to produce hallucinations than levodopa alone, even though I mentioned that they can both occur. I've talked about this idea of impulse control being more common in D2 agonists, although it happens with both classes of medications. But in the D2 agonists such as pramipexole and Neupro, it occurs in nearly 15% of people who have them. It's more severe or frequent at higher doses. So, for example, in people taking cifrol, you wouldn't expect to see it under 3 milligrams, although it can occur to some extent, or over about 6 milligrams of Neupro. It takes time to develop. It doesn't something that you're taking the drug, it doesn't turn up right away. It can occur 6 months down the track, and it just slowly builds up with increasing pressure of thought, people getting a bit stuck and a bit obsessed about ideas and a bit focused on particular thinking, and then finally comes out as being often obsessive behaviours. The stereotypes that are there is that it's around the two ideas that in women it's more likely to be around shopping and eating, and in men around gambling and internet sex. But these are sort of simple rules of thumb. These can all happen to anyone, and they're probably the more glamorous ones. The more common ones are a propensity to just be hoarding, hobbies getting out of control, habits of behaviour that are being driven too hard, which are all troubling to personal relations and the peace and quiet of the house. So when people start on these drugs, most of us would emphasise to pay attention, to look out for them, to let everyone else in the family know and talk about them. One of the things that we found, though, is that this again is this the PKG that is worn on the wrist. And this is a person who had a lot of dyskinesia, particularly later in the day. And what happens here is when they meant to take their medications, they're meant to press the button to acknowledge that they've taken it. Now, we've found that a proportion of people press the button repeatedly. And this is a form of cueing which we think is a bit like a conditioned response, because what we're asking people to do is to press the button, take a medication that's going to increase dopamine in the brain, and this is a way of binding two forms of behaviour together. And this is the reason why impulse control behaviours occur. All forms of addiction are bound by drugs that increase dopamine in the brain, and this is a way, and addiction is just a form of impulse control behaviour. And so what we're really seeing here is with the high level of dopamine, when we teach someone to make an action, then they press the button a lot more. What we find then is that if you reduce the timing of the drug, you can actually reduce the amount of button pushing, and this is what it should normally look like. This is a good early warning that these problems might be occurring, and so it's one of the reasons that we like to follow people on cifrol or these other agents to see how early this is actually arising. These medications also can produce anxiety. We think that it's usually associated with the involuntary movements, and we're not sure whether it's the class of drug or whether it's the presence of the involuntary movements. And what we think is going on is that if someone takes a drug, say a recreational drug like cocaine or a cigarette, what happens is that dopamine rises in the brain in association with taking that drug, and then on the falling phase, people become anxious and agitated, and it's usually attributed to the idea that they're looking for their next fix. It's actually not as cognitively thought out as that. It's actually the falling levels of dopamine make people feel anxious. And so we think that the same thing is happening here, is that the levels of dopamine are high. As they fall, then anxiety comes in, and it's actually that falling level. If we could reduce the falling level, then that level of anxiety would disappear. The last problem with the D2 agonists is that they just, on their own, they're not strong enough. And so they're often okay at the beginning of the disease. They will do the work on their own. But almost always they need to be eventually used in conjunction with levodopa. And that, in a sense, is their downside, but their good side is they remove the ups and downs of levodopa, which comes in bursts, has a high level and a falling level, produces the anxiety I talked about, and I'm going to discuss that rise and fall in a minute. So I've gone through the range of side effects, and when you listen to that, you might feel, well, look, I don't really want to be on any of these drugs. But the point about side effects is that not everyone gets them. Some are mild, some are severe, and you need to actually be aware of which is which, and many of them can be modified if we know that they're present. And when we actually assess what we're doing about a drug, we need to measure the risk against the benefit. And an example I use of this is that if someone had lung cancer and we had a medication which has a 40% chance of death but a 50% chance of outright cure in a condition that you will almost certainly die of in 6 months, you'd probably wear the risk of death for the chance of an outright cure. But if indeed it was the same side effect profile but it was for acne, well, of course you wouldn't use it because it's a much milder condition. And so what we're really saying there is that side effects which are severe are worthwhile if the benefit is great and the consequences are great. They're not worth it if you're not really fixing something that is worthwhile. So when you're assessing things like nausea, yes, it's an unpleasant side effect, but it can be treated and it's not as severe as the long-term consequences of the levodopa. It's worth doing. Impulse control can be hugely damaging to life. Despite what it can do, it's not worth the consequences. So again, you have to weigh those things up against the pros and cons that we're trying to fix or trying to control. So we accept, for example, that there's a 15% chance of impulse control behaviour with Cifrol, but that's another way of saying it's 85% don't have it, but if it's there, you need to do something about it. So what I'm going to talk now a little bit about is when and how we use these medications. So these are very broad rule of thumbs here, but we can divide Parkinson's up into about 3 stages. And this is, don't go home and say 6 years, 3 years, that's 15 years, I've had Parkinson's for 17 years, looks like I'm about to go. These are just rules of thumb. You know, this is for the average person and no one is average. But we can think of there being these 3 stages in which the first 3 to 6 years, the anti-Parkinson's medications work really pretty well, and for most people, this is a phase of the disease that can be well managed. The middle 3 to 6 years are the more problematic ones. Parkinson's medications still work, but many of the complications I talked about are more obvious then. And in the last 3 years is where there's increasing a rise of side effects or complications which can't be treated by the dopamine medications, and in fact actually are often made worse by the dopamine medications. And so we can think of these 2 stages, one in which there's a good dopamine response at first, but it starts to decline, and then one in which there's increasing non-dopaminergic features, and so there's a trade-off over this time. So this is the time in here, this passage in here, where we can think of really our best chance of using the drugs. It's pretty easy at the beginning, and this is where real management of the side effects versus the benefits occur, and this is where it becomes much more problematic because we're often backing off the drugs because of the complications. So again, it's all about dopamine here. It's a lot about the side effects that are related to dopamine here. So the first question I'm going to briefly go through is when to start in this early stage, and what are the options? Well, the options are levodopa and the D2 agonists, and the issues are, is levodopa harmful or helpful? And the second is, does D2 agonists protect from the progression and the development of dyskinesia, and are there long-term complications if you start too soon? So I want to clear up some really important misconceptions here because these are often well entrenched and around for a long time. Side effects don't occur early if you start the treatment early. The time from the onset of side effects is really related to the time of the onset of disease. So if I was to develop Parkinson's today and I chose not to take any medications for 5 years, my chances of getting side effects at 5 years would be those of someone who'd had Parkinson's for 5 years, not for someone who'd been taking levodopa for 6 months. So it's the duration of the disease, not the time you've been having Parkinson's medications. So there's no point in waiting for some time to avoid the onset. If you start the levodopa now, it doesn't mean that you're going to have an increasing demand later on, that you'll end up resistance, and that's really related to the progression of the disease and not related to how much dopamine you take now, or levodopa or D2 agonist. There's absolutely no evidence that one class of drug is superior to another at the outset of the disease. So the pharmaceutical industry tells us that one is better than the other, and there is pros and cons of one versus the other, but there's never been a study which has actually put the two head to head and says this people do better than the other. There is probably true that if you take the D2 agonists at the outset, it takes longer to get dyskinesia, but that may simply be because they are not strong enough on their own to actually produce it. Nothing else. We don't know for that for sure. It's possible that you get dyskinesia earlier if you take levodopa. That's probably just because it's stronger than the other drug and therefore able to produce it. It's probably nothing more than that. There is circumstantial evidence, but not convincing, that taking levodopa may actually even slow the rate of progression down. There's no evidence that taking levodopa hastens the progression of disease. The other point is that the best response is in this first stage, which we talked about. So if you don't take the medications early on, you actually waste this opportunity and actually are not taking the advantage of that time when the medications are working best, because stage 2 will come regardless of what you or the doctor does. So you don't build up bonus points later on by being abstemious now. You might as well take the benefit at the beginning. Now, why do the complications occur? So I talked before about the idea that these are little bags which store dopamine. They're a bit like a dam. In the normal brain and the normal terminal, we only use about 15% of the dopamine made. And it's stored back in here and just dribbled out at low levels as it's required. In early PD, it's as if there's been a drought for a long period of time. There's too little water or dopamine being produced, and so the dam begins to run dry, and eventually there's less, not the normal low stream, there's a trickle coming out, and so symptoms begin to occur, and it's possible to replenish the dam with levodopa or dopamine agonists. Eventually, though, the dam actually disappears. And so then you're at the mercy of the drought, which is too little. That's when there's no medications, or a flood when there's too much, which is when there's the peak dose of the medications. So it's this ebb and flow because there's no capacity to store because these terminals have eventually disappeared that causes the rise and fall of the symptoms. I'm going to use this another way because it's a key idea. We can imagine that the terminal there is a big bath of water or a sink of water with dopamine slowly filling it up all the time and a dribble coming out here releasing it at a steady state. When Parkinson's occurs, the sink's a bit smaller, but more importantly, the tap is dried up and it's dribbling at about the same rate or even slower than what's coming out, and so eventually this runs dry and the symptoms of Parkinson's occur. And you can replace it by increasing the rate of synthesis by using the drugs. So we can think of this as being a barrier here. This is the amount of medication that you're wanting to have, and this is the amount that's in the times where you take the medications. And if you're down here without enough being replaced, you're down here too low, and we're wanting to push it up into this window which is just right. Not too high, but just above the level. So we're wanting to bring that up so that there's dopamine in the storage and it's continuously being released as you need it. Eventually things come so that the storage is too small, there's no internal dopamine being produced, and so there's no outflow. And so there's no timing of no production of dopamine unless medications are taken. And then the medications occur and it produces a whole lot which is immediately produced, but you can't store it. So it overflows over the edge and there's a flood, excess dopamine's produced, and it's really a bit like taking a drug of addiction. It overflows and spills out in the brain and there's too much, but it doesn't last long because there's no storage capacity, so it's short-lived. As a result, you get this rise and fall in dopamine where it's too little, no storage, overflow, too little, no storage, overflow, going bouncing up and down every time a dose of levodopa is taken. And when you get up into here, that's where you get the involuntary movements and the impulsivity. As it falls, that's when the anxiety and all of the other symptoms occur. And so you can see that what we're then faced with is the problem, couldn't we just smooth it out in some way by giving a long-acting drug? And that's what we would try and do, is to actually use the D2 agonists to smooth it out, but eventually this window becomes too small and we can't make that target accurately enough, and that's when oral therapies fail. So again, going back to the PKG, this is a person who is taking 4 doses a day, and you can see that their bradykinesia, this is the blue line, their slowness of movement, slow in the morning, medications work, last for 2 hours, then the drought comes and then they go up pretty good, wear off, and they haven't got too much involuntary movement. There's not too much of the green line up there, so they're not moving excessively. In response to this, the doctor here chose, instead of taking the tablets 4 hourly, you're wearing off at 3 hours, why not shorten the interval? And you can see what's happened is that it's smoothed out the bradykinesia line, but the price has been a whole lot more involuntary movements. So the options when you're faced with this problem is more frequent levodopa, Sinemet, which is what's been happening here, or a long-acting D2 agonist to help support this and smooth out the bottom, or prolong the action of levodopa using those enzyme blockers, etc. Most neurologists would, at this stage, get these two working in harness, working together, so that you don't have to have too high a peak of levodopa every time. And so the Cifrol and the Nupro are carrying some of the load in smoothing it out, but not all of the load by themselves. But it's when this problem occurs that despite your best endeavours to get the line just right, the dyskinesia and the involuntary movements occurs. That's when you need to start thinking about the long-acting agents like deep brain stimulation or the pumps. So again, this is some information from the PKG. If we look at people who've had disease ranging from 0 to 18 years, so these are early symptoms, and this is a score which the PKG produces, which is a fluctuation score. People early in the disease don't fluctuate much. But there's a band in here which is ideal, and many patients can be held in this optimum band for many, many, many years, 15, 18 years. It shows that not everybody gets these involuntary movements and things get out of control. But a proportion of patients end up in here with very high levels of fluctuation, and these are the people who need advanced therapy because, in fact, the treatment can't bring it down into this grey window. This leads us to think that what actually is happening is that this is where people without Parkinson's are, and as you get Parkinson's, you get less and less a range of repertoire of movements. As we then start to treat it, you start to remove or return back towards a normal variation in movement, and some people stay close to that level for much of the disease and never really develop severe enough fluctuations for, that become troublesome. But a proportion of people do. Then we use an advanced therapy to try and bring them back into the window. So with the oral medications, what we're trying to do is to shift people from here and keep them up in this optimum level of control as long as possible, and if hopefully all the time, so advanced therapy is never required, but a proportion of people are going to end up requiring advanced therapy. Now, I just wanted to spend a little bit of time talking about what's coming down the window, down the pipeline of therapy, because what people are trying to do is to develop drugs which will be able to be taken orally and avoid the need for the advanced therapies. So, as levodopa isn't continuous, it wears out every 3 hours, and so therefore it comes in pulses, overflows the dam, dries out, overflows, dries out. And because the D2 agonists on their own aren't strong enough, then we need those deep brain stimulators and the pumps, etc. And I've really covered that point there, but what's coming is then, if we were able to have these other agents, then the DBS, etc., wouldn't actually be required. So some of the things that are coming, there's these drugs which have, unfortunately, they still have unpleasant pharmaceutical names like the adenosine 2A or A2A agonists, and they've got names like Preladinant and Tosedinant, and something more digestible will come along the way. But these are all stage drugs that are actually being trialled in humans at present, and are either in phase 2 or phase 3 trials. So literally, if they work, they will be available at the clinic probably within 3 to 4 years. And there is clinical evidence that these are all that's meant to be helping in wearing off. There's a number of drugs which are levodopa formulations, in other words, the same as is in imidapar and Sinemet, but they have increased duration of action. There's this compound with the very pleasant name of IPXO666, which is an extended release formulation of imidapar, and it seems to, at least in clinical trials, have a very much longer duration of action and doesn't have quite the same ups and downs. There's this other one, XP21279, which is a sustained release as a prodrug and promises to be a very long-acting drug, perhaps even over a day. And the ND0611 is a patch that can be worn which slows down the breakdown of levodopa in the circulation. And there's another drug called sofenamide. Since putting this up, I've heard that it actually may not have actually passed the trial, so that's a bit of bad news. So another interesting drug, this is a paper that came out in 2015, so very recently, called a drug called Ldl Protein, and this is related to an antidepressant drug, and Its preliminary evidence in humans, so it's being trialled in people, seems to be that it slows down the rate of progression, or it slows down or treats dyskinesia. It's already available as an anti-dyskinetic drug, so as an antidepressant drug, so it's safe. And so there's a long-term study now underway to see whether it's more effective. I mentioned this other drug before, this one called SYN-115. These are for motor fluctuations, and so that's been already trialled in 2014 and again looks very promising. So I think there is some hope in this with these particularly new pharmaceuticals coming, that some of the advanced therapies may indeed be possible to avoid them, and I don't know whether these particular ones will actually get to clinic, but I think there's reason to be optimistic that there will be drugs that get to clinic. So I will stop at that level, and I'm just going to leave up my normal advertisement for the Australian Parkinson's Disease Registry, and you can read about that. But I have time for some questions. Those of you who have an urgent tram to catch, feel free to leave, and I won't be at all offended. So please feel to ask a few questions.